good morning, or whatever time you're listening. I guess it's good morning for me, but I know you're going to come in at all different times, and even probably late at night. Somebody asked me to share my screen, which I thought I had always been doing, but I can't exactly tell because I'm looking at myself right now. But I do have clicked on to share the speaker, and that's me. So hopefully that little window with my face is there. And so I'm going to go right into sharing screen and share the subject matter of what we're doing today right then. And here we go. Let me make it big. Okay, so we are dealing with the cranial nerves now. And I do see my little picture, so I guess I think it should be there. And am I recording? Let me just make sure. Yes, I'm recording. All right, so we're going to look at the cranial nerves, and I kind of think that none of the information on these slides is new to you because you have looked at the ascending pathways in lecture number 2, I think it was, and we did plug in the cranial nerves to it as we went through. And then we looked at the motor pathways and we plugged in the cranial nerves to that. And then I'm going to fill in some details that you haven't heard in this course, including about probably a dozen different muscles that we should be aware of as SLPs that we can actually test them to some extent anyway. And certainly want to know if there's a problem with specific muscles that are going to give a very obvious kind of feature characteristic if there's a problem with them. So a few muscles, so that's a level of detail, but I think you've gotten that detail actually in your anatomy and physiology course. So I think probably none of this is totally new, but we're orienting or organizing the information in a different way. It's going through the cranial nerves one by one and looking at what they do and how they plug into the systems we've talked about. And any particular muscles we need to be aware of, and also how you would assess them. I do kind of go through that as we go, and then at the conclusion, I have a videotape from YouTube, about 10 minutes long or so, I think, of a cranial nerve examination done by a nurse. I think I really like it. I think it's quite clear, and it's pretty close. I bet 90% to the way I would actually do it, and it's perfectly fine the way she does it. I think she might go into a little more detail on the examining visual fields that I do. I just look at right and left basically, and she looks at quadrants, and also she tests olfactory. And she does also test the cranial nerves 3, 4, and 6 associated with extraocular movement, and also the pupillary reaction to light. And we, as SLPs, I think most of us just screen for that. We don't do specific tests, as you will see her do. It only takes her a couple minutes, but other than that, I think it's pretty right on. So that's there. And then, as I said, I would view it as a supplemental lecture at the very end. There is a lecture about a half hour long by a guy who's recorded a lot of stuff about neuroanatomy on YouTube. And it's about the cranial nerves, of course. And I think it's quite good. And the pictures are different. The explanations are in his words, not mine. So I think if you're feeling uneasy still, you want to refer to Webb, of course, because Webb is your reference. And you can always do Wikipedia searches and so forth, Google, and also that video. So that is my introduction to the cranial nerves, and let's go right into it. This is a slide, I believe you've seen it at least once in this course and probably before. I think I got it from Webb. In fact, I know I got it from Webb from this chapter 7 that we're looking at right now. And this is simply the name of them, the name of the 12 nerves and the function. And then just a reminder that olfactory, we're really, as SLPs, generally not going to test it. The optic, excuse me, I don't mean to move that. The optic nerve, we do test not the nerve itself, but that cranial nerve. I mean, we look at the visual fields, and that's very important. You can't do some of the language tests that we use that, for example, have an array of objects out in front of them before we've tested the visual fields, because we want to know that they can see in the right and the left visual field with both eyes. Or if there are some limits, we need to know that. And then the 3, 4, and 6, I just screen, just a reminder, I told you this yesterday, I just screen it by looking at the coordination of eye movements. eyes. And if you see that one eye is moving differently from the other eye, that is referred to as a strabismus, and it definitely does mean that there's a problem with the nerve, or it could be the nucleus, the motor nucleus that has the cell bodies that make up the nerve. So one of those, so those, let's see, that's 4 we're really not going to deal with except for screening on the extraocular ones. And the optic we do take a look at. So today we're going to concentrate on the ones associated with speech production and also swallowing. And that would be 5, 7, 9, 10, and 12. I'm going to mention accessory as we go through it briefly. And it's very easy to test it, but it doesn't really pertain to speech directly. And then 8, of course, does pertain to speech. You have to be able to hear in order to engage in a typical communication. And so we want to be aware of any problems in that area. But you have a whole course, or actually 2 courses, a course and a practicum to give you the skills to be able to screen people. And we do screen our patients in a very simple way, generally not with an audiometer. So that's just my little introduction to the 12 cranial nerves and an indication of the ones we're going to be focusing on. So I want to remind you about the cortical bulbar tract, which we spent quite a bit of time on in the previous lecture, and that it provides upper motor neuron input to the ocular motor nucleus, the trochlear nucleus, the abducens nucleus, the 3 we can sort of put to the side. Also the motor trigeminal nucleus for chewing, the facial nucleus for control of facial muscles of expression, the nucleus ambiguus, which controls the velum, the pharyngeal muscles, and the intrinsic laryngeal muscles, and the hypoglossal nucleus. So you're going to see these returned to, but those are motor, and we're not doing just motor. We're also doing sensory. This is a slide. It's just a kind of a reiteration of what I said a few minutes ago. Number 1, what it does. I'm going to leave it off. Number 2, we've already dealt with it. And number 3, 4, and 6, extraocular movement, and we just screen. If those eyes move together, we can forget about 3, 4, and 6. All right, this is the location of the nuclei I just talked about. I'll briefly mention 3, 4, and 6. 3, the ocular motor nucleus, and 4, the trochlear nucleus, are located in the midbrain. And the abducens nucleus is located down in the pons. So there it is. And occasionally you will see a patient who has, I'm just going to give you a quick example that will happen. You have somebody with a brainstem stroke, and as a result of interrupting pathways, and let's say it's on the right. So as a result of interrupting ascending sensory pathways and descending motor pathways to the body, that right side stroke in the pons will result in a left hemiparesis and left side loss of pain, temperature, fine touch, and proprioception. Now, if that stroke in the right side of the pons happens to involve the abducens nucleus, they will also have a problem, and we put the stroke on the right. They're going to have weakness or paralysis of the right lateral rectus, which means their right eye is going to go off to the side. Excuse me, it's going to go to the middle because they don't have that lateral rectus pulling it over and keeping it in alignment. So that eye on the right will deviate to the midline, and it will not be coordinated with the other one. So I'm giving it as an example of just how clear it will become when you get the brainstem strokes that involve these nuclei. That when you see that patient, you see the left hemiparesis, and you think, oh, okay, I probably a stroke up here on the right motor area of the cortex or cerebrum someplace. But then you see this eye thing going on, which doesn't fit because it's the eye on the opposite side. And you think, what's that? It's because it's a brainstem stroke that interrupted that nucleus and then the other pathways we talked about. So in that sense, it's important to keep these in mind, but we don't dissect them in our clinical analysis to the degree we do the others. Okay, let's look at 5, the motor nucleus of 5, and it is, where is that? Trigeminal motor nucleus right here. And then here's the facial motor nucleus right here. They're both in the pons. And then nucleus ambiguous we want to look at. Where is nucleus ambiguous? Right here. Yeah, right here. It's a long nucleus in a cylindrical shape in the medulla. Runs just about the length of the medulla. And then the hypoglossal nucleus right here. Also a long cylindrical shape that runs the length of the medulla. So you begin to get the picture that if you have a medullary stroke or something in the medulla, that you could have involvement of the pharyngeal muscles from nucleus ambiguous and the intrinsic laryngeal, and also the hypoglossal muscles. And we'll look more at those pathways, but I just wanted to show you where in the longitudinal organization of the brainstem these particular nuclei, motor nuclei, are located. That's the purpose of this slide. Okay, and this is another reminder of the nerves for speech and hearing. We're going to concentrate on them. Trigeminal and facial, of course. Vestibulocochlear, you'll do that in 464 and your other 465, I think it is. No, not 460. 464, your undergraduate audiology class, and then your audiology practicum. You'll deal with that. We're not going to deal any more with it, except to remind you that, of course, you need to screen for it as an SLP. The glossopharyngeal nerve, number 9, the vagus nerve, spinal accessory, it's easy to test, but it doesn't actually do speech. And number 12, the hypoglossal. You certainly do need the tongue for typical speaking. Okay, now let's go nerve by nerve, since we've identified the ones that we need to focus on. And we'll try to start with the trigeminal, and I'm going to start with the sensory part. And you've already actually seen this in lecture number 2, but here it is again, and maybe with a little more detail. That sensory nucleus is actually a 3-part nucleus. It has a part in the mesencephalon. It's called the mesencephalic trigeminal nucleus, or just the mesencephalic nucleus. It's got the main trigeminal nucleus in the pons, and it's got the spinal trigeminal nucleus, which extends down to the bottom of the medulla, the very bottom part. And so it's a long interconnected one, but it's divided into 3 functionally, not anatomically, in the sense that they're not actually separated, like 3 different islands separated by water. They're not separated like that. But the mesencephalic subserves proprioception and kinesthesia, whereas the main subserves fine touch and proprioception. So I've given the location, the midbrain for the first, the pons for the second, and then the functional distinction. So they're separated functionally, but not anatomically, if hopefully that makes sense. And and then the spinal trigeminal is located a little bit in the pons, but extends all the way down to the through the medulla, and it subserves pain and temperature sensation. Now, we're going to kind of put that one to the side, however, because as SLPs, I don't think we're really going to test pain and temperature sensation for the face. But all 3 of those do deal with the same region. It's the whole face, and it's the whole oral cavity back to the oropharyngeal port. So once you get behind the oropharyngeal port, you're in the pharynx. That's a different cranial nerve. So we're just doing 5. We're doing the sensory component of 5, and realistically, the part that we would test as SLPs will be this. We're going to test light touch, and if they have a deficit in light touch because of their sensory problem, we're going to see manifestations of that in speech and in swallowing also. Many times you'll see strokes, let's say on the left side, right hemiparesis, right loss of pain and temperature, and fine touch and proprioception. Then you get into the mouth, and they eat something and they swallow, and they've got a lot of stuff left over in the right side of the mouth, in the buccal region, buccal cavity, or sublingually, that they don't feel. That's why it's left over. They don't feel it. And so they complete their swallowing, and there's still stuff there. So we definitely are concerned with that, and that's what we test, not pain and temperature, and not really proprioception and kinesthesia either. All right. Now let's look at the motor part of trigeminal. It does have a motor part, and basically it's for the muscles of mastication. It has a couple little muscles we'll get to at the bottom of the slide that don't have to do with mastication, but as SLPs, we don't test those. So let's look at them. They all these motor neurons are carried out with the mandibular division of 5. The ophthalmic division and the maxillary division, they're only sensory. All the motor is contained in 5 and sensory as well, but 5-3, or I'm calling it 5-3, which is shorthand for the mandibular division of 5. And now we can take those neurons and divide them into kind of 6 categories, depending what particular muscle they're going to innervate, muscles of mastication. There are 3 mandibular elevators, and there are 3 mandibular depressors. You close your mouth with the elevators, you open your mouth with the depressors. And there are 2 of them that are really easy to test, and you will see them tested on that video demonstration, the temporalis and the masseter. Temporalis up here, masseter right in here. So if you do this, you can do it yourself right now. Just clench your teeth and you will feel the masseter clenching equally, hopefully, on both sides. Same for the temporalis. You'll feel the movement there. The medial pterygoid is a very, very important mouth closer and mandibular elevator, but it's deep, so you can't actually feel it. Now we can test it and actually see if there's a unilateral weakness or a bilateral weakness. We can test it, but you can't do it by palpating. You do it in a different way we'll get to. But how is that muscle? You know, there are 2 pterygoids, the lateral and the medial. The medial one is the depressor, and I would invite you just to go back to the notes from your anatomy and physiology class and look those up and see the pictures of the 2 muscles, and you will be able to see geometrically why the medial pterygoids are jaw elevators, but they are. And so if you have a weakness in them, chances are you have a weakness in the other 2 as well. So we test these by palpation, touching during mouth closure, and the medial pterygoid by observation, and I'll show you in a minute how we do that. We're just going over the basics here now. Okay, now back here, there are 3 mandibular depressors. One is the lateral pterygoid, the partner of the medial pterygoid. And again, that you can't palpate it directly, you won't feel it, but you can see the effects of it. And then the anterior belly of the digastric down here, that kind of makes sense. It's attached to the hyoid bone, and it makes sense that that would pull your jaw down. And then the mylohyoid jaw muscle as well. But the lateral pterygoids are really powerful, really powerful. If you look at a pit bull, and they've got these massive, that's their pterygoids, and that's why they can clamp down and do so much damage. Okay, the 2 other muscles, because there's a total of 8 muscles innervated by the mandibular division of 5, they are not associated with speech, at least not in a testable way. The tensor veli palatini, it's in your palate, it's in your velum. There's no way to test it differentially. You can't get in there and see anything. If you somehow had just that one muscle weak, I don't think you can figure it out, basically. Unless you probed it with an electronic device that can detect the activation of a muscle, which certainly we're not going to do that. And then in your ear, the tensor tympani muscle, well, we're not going to, audiologists can test it, but SLPs don't. And just as a reminder, the last point, the innervation of all of these muscles we're talking about, 8 of them, 6 for speech, are innervated by the mandibular division of 5. Okay, enough said. These are the 3 sensory zones. The ophthalmic branch, for basically from the corner of your eyes up to the top of your head and the whole forehead region and a little bit of the nose. A pie-shaped wedge that includes your upper lip and goes up to just above your ear is innervated by the maxillary division. And then the mandibular division is basically from your lower lip and back to your ear, this region down here. Show it without trying to move my slide, which is so easy to have happen. Now, this is very important, this and this, because it's a reminder that the maxillary division does not just the skin that we see over here, not just the surface of the face in that pie-shaped wedge. It does everything deep to it, in the roof of your mouth. It's the upper lip, it's the upper alveolar ridge, it's the upper teeth are innervated, the palate, and all the way back to the velum, to the edge of the velum, back edge of the velum, all innervated by the maxillary division of 5. And then the mandibular division is the same thing. It's not only the surface of the skin here, it's the floor of the mouth. It's the lower, it innervates the lower lip for sensation. It innervates the floor of the mouth, the anterior 2/3 of the tongue for general sensation, not for taste. We'll get to that. And so I want you to remember, it's everything deep too. And we certainly do test that. We're talking about general sensation. Now, the other aspects of sensation, like proprioception, pain and temperature, kinesthesia, the neurons carry, other neurons that are with these branches carry that, but we're not going to test it. Okay, now I just want to show the location as a reminder again of the sensory nucleus that we're talking about. Here's the mesencephalic trigeminal nucleus in the midbrain, the main sensory nucleus of the trigeminal in the pons, and then the long tail extending down into the medulla for pain and temperature. We're concerned with this. All right. Okay, how do we test it? So what we're going to do is think about the face and the oral cavity divided into sections. The face into 3 on each side, so that's 6. We're going to test in 6 zones. I often don't test up here. I just test in 4 zones. Why? Well, because if you're in a healthcare environment, and especially in the acute care environment, which means it's newly admitted people who've just had a stroke or a head injury or whatever they were newly admitted with, they're sick, and their endurance is not so good. So we are trying to get the essential information that we need, and we don't want to spend extra time and their extra energy doing anything that isn't really critical to developing our diagnostic statements, our assessment of prognosis, how we think they're going to do, and a treatment plan. So out of that initial evaluation, we need to do that all. So you got to cut some things out sometimes. That's why I generally do here, the 2 maxillary zones and then 2 mandibular zones. And then we get into the oral cavity. There's 2 for upper, the 2 maxillary zones inside the oral cavity, and the 2 mandibular. So here's just a reminder that many SLPs would just do, is that 8? 2, 4, yeah. 4 on the outside, 4 on the inside. Both sides we're talking about. So that's a total of 8. All right. And how do you do it? Just light tactile stimulation. You like that, or you could use a Q-tip. It's light tactile. You need to have them close their eyes if you could possibly get them to understand the instructions, because otherwise they see you touching and they think they feel it then. So the best assessment would be one that only has input in terms of this one modality we're talking about, a light touch. All right. Now, how do we test the muscular aspects of 5? We're going to assess the general strength of mandibular elevation. And we're going to do that by palpating the masseter and also the temporalis as the patient clenches their teeth, and also their resistance to us pushing down. So if you ask them to close their mouth and then we go like this, like we're trying to pull their chin down, that's a test of the general strength. I mean, you can kind of see if they're functional that way. And then the general strength of mandibular depression is assessed by putting our thumb or fingers under the chin and asking them to open their mouth against that opposing force. Then for symmetry, this is where that lateral pterygoid comes in. And so again, I want you to review your anatomy and physiology course information about those 2 muscles, lateral and medial pterygoid. The lateral pterygoid, they open the mouth, and they're the biggest, most powerful muscles to do it, even though they're hidden and you can't see them, but you can see the effects. So if you're just asking them to open their mouth against your opposing force of pushing the jaw up. You're testing them in general, and you can see if they're pretty strong, but you can't see the symmetry really. And to do that, what we're going to do is to ask them to protrude their jaw. So when you protrude your jaw, the only way you have of doing is to contract those lateral pterygoids. They run basically from front to back, and so they pull the whole jaw forward if the person also is keeping the mandible relatively elevated. So they would tend to open the jaw if you don't try to keep, if you just contract your lateral pterygoids and you don't try to keep your mouth closed, more or less closed, you'll open your mouth. That's what they do. But if you keep the mouth relatively closed and just say protrude your jaw like this, what's going to happen is if they have a unilateral weakness, and let's say the weakness is on the right, the left one is going to pull out and the right one isn't, so the jaw is going to go like this. In other words, the jaw is going to deviate to the side of the weakness of a lateral pterygoid that is weak. So it's easy to test the symmetry of the strength by jaw protrusion. And again, this kind of makes sense. I think if you're going to ask somebody to protrude their jaw, obviously they're going to keep their mouth relatively closed. They're not clench their teeth because then they can't do the movement. But just do it yourself right now and you'll see. I'm going to protrude my jaw. And it comes out on the midline because I have two strong lateral pterygoids that are symmetrical. So that's how we test the muscular. Now let's go to the facial. The components of the facial are a branchial motor, and I'm going to just kind of jump ahead here, then name them: branchial motor, visceral motor, and special sensory. Now I want to come back to branchial motor and just remind you of what we talked about yesterday. Branchial motor is kind of it's in your book, so I want to have you recognize the term. All it really means is it's a motor nucleus in the brainstem. It's in a certain category, somatic motor and branchial motor. They derive themselves in a certain way embryologically, but the important thing is branchial motor neurons innervate striated muscles. Where? Up here, the face, the pharyngeal cavity, and the larynx, not the tongue. The tongue actually started to grow down here from a somite, which grew the muscles in the rest of your body, and then kind of migrated up and ended up there, and it dragged the neurons with it. So it's a little bit different, but it doesn't matter for our understanding as clinicians. Branchial motor neurons innervate striated muscles up here, except for the tongue. And the functional consequences of even that distinction are not important. The nucleus that has these neurons in it is the facial motor nucleus, or it's just called the facial nucleus. And what does it do? It innervates all the muscles of facial expression. All those ones we all had kind of a time learning those because they're not geometrically real simple. They kind of cross over each other and everything, but it's all the muscles of facial expression and the platysma. That's considered, like if you go like that, you're using the platysma. And also two other muscles that are kind of incidental in a way: the stapedius muscle, it's in your middle ear, and the posterior digastric, but we don't specifically test those at all. So I'm putting it down there as a detail so you know, but what are we going to really test? The muscles of facial expression. Okay, now let's go to the next part, which is visceral motor. There is a visceral motor nucleus, and it innervates the superior salivatory nucleus. We're not going to test that as SLPs. I think you need to know that it exists, but I don't think you're ever going to put it in a report, and you're not going to specifically test. And it can be done, by the way. They can measure the production of saliva from a particular gland and come up with a conclusion about this component of the facial nerve. The next one is important to us, and that is the special sensory. It's sometimes referred to as special visceral afferent. It is sensory. What's special about it? It's not like just light touch and tactile and kinesthesia or anything like that. It has to do with some kind of sensory or afferent input for digestion. And in this case, it subserves taste. It subserves taste for the anterior 2/3 of the tongue. And what is the nucleus? Nucleus solitarius. And so there's a few neurons, well, quite a few actually, in the facial nerve that are carrying taste information from the anterior 2/3 of the tongue, and they're going to track back and end up in the medulla and the nucleus solitarius, which we have looked at before. And then the next thing for 7 that's sensory in nature is a general sensation. And I put it in red because it's just incidental. It's in your book. So I thought, well, don't think I just forgot about it or something. But what does it do? It subserves pain sensation for the external auditory meatus and the tympanic membrane. In other words, if you jam a Q-tip into your ear and hit the tympanic membrane, you're going to feel it. And this is the nerve that carries that information. And where does it go? The spinal trigeminal nucleus, pain. Okay. So we don't test that. All right. This is kind of important. This is a illustration of the pathway of the 7th cranial nerve to all the muscles of facial expression. So you can see it's dropping out here of this stylomastoid foramen, right by the styloid process, deep to it actually, and comes out and fans out into a big tree that goes to all those sections we've talked about: upper, middle, lower third of the face, and the deep areas for the maxillary and the mandibular. Importantly, the trunk of the tree goes through the parotid gland. Now, where is the parotid? What is it? The parotid gland is a salivary gland. It's a big one, and it's right here in front of your ear. It's a surface. It's relatively surface. It's just beneath. It's just beneath the skin and the fat layer. And occasionally, some problems can go wrong with it, like a little cancer or a little tumor, and the surgeon will try to remove that and can nick the trunk of the facial nerve, in which case you'd have an ipsilateral loss of facial sensation and some muscular problems, because if the mandibular division is involved as well. So you will occasionally, especially if you work with head and neck cancer, see patients who got that problem. They had an issue here, and possibly as a result of the treatment or the tumor or both, they have a facial loss of sensation on that one ipsilateral side. It would be the side where the problem was. So I think this is kind of important to realize that it comes out from the base of the skull through the stylomastoid, and then the trunk has to make its way through that parotid gland, and then fan out into the big tree structure and all the places it goes. All right. This is a pathway for taste. Now, I've put all this in red because you can see it's not very direct. It's kind of like the the exchange up in LA where the 5 crosses the 405 and it crosses, I don't know, a bunch of freeways, and they're all layered up, and it's a little more anatomical detail that I think we really need to know. For a while, even though we're talking about taste and a general sensation for the anterior 2/3 of the tongue, 5 and 7 both get involved, and they kind of cross some neurons with each other. So all I really want you to remember is general sensation for the tongue is subserved by the mandibular division of 5, and taste is subserved by the 7th cranial nerve. Now, what happens is, just to make a long story short, the mandibular division of 5 does carry those neurons for a little distance back toward the brain, and then they kind of cross over and get involved with 7, and then the taste fibers, which are afferent, they're sensory, they end up in the nucleus solitarius. So I've tried to reduce this to this. It's the facial nerve. It's a pathway for taste. What taste where? Anterior 2/3 of the tongue. 7th cranial nerve carries them most of the way, not the whole way, back to the nucleus solitarius. That's as simple as I can make it. So we're not going to go into these details. You will never see this on one of my quizzes. I'll guarantee you that. Okay. Now, back to muscular function for the face. You've seen this now, I think, 2 times in different ways. And what I'm trying to illustrate here with these various colors is that here's a facial motor nucleus. Here's another one on the other side. There's a little face arranged in there, by the way. It's also somatotopically organized. It's kind of amazing. And the part of the nucleus that controls up here gets input from both sides of the brain, both motor cortices, equally. In other words, bilateral. Whereas the part that subserves the lower 2/3 of the face gets input that's almost all crossed, about 80%. Going back to that table we were looking at, if you'll see face upper third, lower 2/3 separated. And this is an anatomical illustration of that fact. Here, the dotted lines for the upper third, or this nerve for the upper third, and over here as well. You see they're dotted because they have input from the orange and from the green. That's why they're green and orange. Whereas for the lower 2/3, this is all orange. The upper motor neuron is here. Okay? So that's all. This is just an anatomical illustration of that fact, and accounts for why, if you damage a facial nerve down here, the trunk of the nerve, let's say as it comes through the parotid gland, with a surgical misstep or whatever, you're going to have a unilateral facial paralysis. Whereas if you damage on this side, you can have a unilateral facial paralysis on this side. And if on the other hand, the damage is up here in the upper motor neuron, it could be the internal capsule, could be out here in the facial area of the motor strip, you're going to have lower 2/3 of the face on the opposite side grouping. And we'll look in the next slide, I believe, at the actual testing of that. Okay, so how do you test the facial? For taste functions, I don't think SLPs, at least I don't think we test taste, at least in a localized manner. If a patient has problems with taste, and you will see, and especially in the elderly, far more often, elderly have loss of taste that is bilateral. It's not a focal thing, and it's a problem because they can fail to eat enough and not have an appetite, basically. And that's not because they have a nerve problem. It's because they have something that's more generalized. So neurologists can figure that out. SLPs are only concerned if a patient has such a generalized loss of taste function that it's affecting their appetite. But I do not believe that we specifically try to figure out pathways and stuff like that. For muscular functions, it's kind of easy. We look at the face at rest, just look, and you're looking for asymmetry. We assess the degree of lip retraction, and we're looking at symmetry again, and we assess the symmetry of eye closure and eyebrow elevation. And I think in the next several slides, we'll see some of that. So now in this task, we're just asking them to do everything. Elevate like you're shocked, elevate your eyebrows and retract your lips. And the task is to smile as big as possible while raising both eyebrows. And so my question is, looking at this face, does this person have a peripheral facial palsy? The word palsy is kind of an old-fashioned word. It just means weakness. Do they have a peripheral facial weakness, which is also called a Bell's palsy? And I want to just say something about this. It's called peripheral facial palsy, which is doesn't exactly ring out with meaning until you know what it means. By peripheral facial palsy, they mean the meaning is a facial weakness caused by a peripheral nerve lesion. So that would be illustrated by the person whose facial nerve is coming through the parotid canal, a parotid gland on the right, gets damaged in surgery. they have a right peripheral facial palsy, also called a right Bell's palsy. All right, just to define it before we go on, a central facial palsy would be weakness of the face caused by a central or an upper motor neuron in the brain, upper motor neuron lesion. And then, of course, you can have no palsy at all. So we'll see an illustration of all of these. What is this one? This is no palsy. That's normal. You're looking at symmetry. You're looking at good retraction, good elevation, and it's symmetrical. All right. Now, what about this one? Again, the task is the same. And what do we see? Do we see good elevation? Is the upper? Yeah, I do. I see wrinkles up here, which means he's contracting the muscles of the forehead. I see symmetry in the eyebrows. I see both eyes open. But this might be a little hard. Is this droopy? Well, yes, it is. And another telltale sign is that he has reduced muscle tone here. And therefore, the functioning muscles here are pulling the mouth over. If you look at this is not quite on the midline. Isn't that called, what's that thing called? That little groove that comes straight down from the middle of your nose. It's pulled over to the stronger side in his case. And so he does have a left central facial palsy. The facial weakness is on his left side. The damage is someplace above the facial nucleus on the opposite side. That's the only way you could get this pattern. It could be up at the cortex, it could be the internal capsule, it could be the midbrain, but it's above that facial nucleus. If the damage actually took out a facial nucleus, you'd have a Bell's palsy on the ipsilateral side. So this one is an illustration of a central facial palsy. Okay, now how about this one? Oh, this is a really good one. So now let's look at up the upper third. You got wrinkles over here, no wrinkles here. You have a high eyebrow here, a lower eyebrow here. He can't close the eye tightly, and you see he's got redness because he actually can't close his eye well enough to keep it lubricated. And then you see a very significant right facial, yeah, that's his right facial droop. And if we ask him to retract his lips, which I guess they are, because here they are retracted here, but not here. This is a very, very significant palsy. And this is an illustration of peripheral facial palsy or Bell's palsy. So how do you get a Bell's palsy? This is not quite understood exactly, but some people, after they have an infection of some kind, it could even be the flu or something, for some reason, they get involvement of the facial nerve. And it's the neurons, it's the motor neurons. And then they get this Bell's palsy. Usually it's unilateral. And hopefully it goes away. It doesn't always go away, but hopefully it does. Another way is that you could have a stroke in the pons that in his case involves the right facial nucleus. And that is the same as snipping that facial nerve in the sense of the muscular function. You wouldn't be able to distinguish the difference. So how do you distinguish the difference? If it's only a Bell's palsy, this is the only problem he has. If it's a stroke in the pons involving his right facial nucleus, he almost certainly will have a left hemiparesis and a left side loss of fine touch and proprioception over his body. We don't even have to test everything else. I mean, we will, and you'll see a pattern. But that in itself, just that, tells you that is a brainstem stroke. So I'm kind of showing a pattern here, hopefully in my couple illustrations so far, that when you get this mixed laterality, first of all, look to the brainstem, and then where you have peripheral nerve signs, that kind of tells you where it is. In this case, he's got this Bell's palsy, so it tells you it's in the pons and it involves the facial nucleus on the side ipsilateral to the Bell's palsy. All right, it's a lot of stuff. I know that. Let me make sure I am recording. Well, actually, I can't see, but I'm sure I am. All right. if I'm not recording, you'll never know about it because I'll do the whole thing again. All right. So now, how about this guy? What's going on with him? So again, the task is to raise your eyebrows and smile real big. We see the wrinkles on his left. We see retraction on his left. This is an illustration of a right Bell's palsy. It doesn't look quite as bad as the previous one. So right peripheral facial palsy or Bell's palsy on the right. All right, we're making progress here. Now let's go to glossopharyngeal nerve. It too has a branchial motor component. What else had a branchial motor component? The motor nucleus of 5, the trigeminal motor nucleus for the chewing muscles. And so now we're ticking down the brainstem a little bit, and we've gotten down here, and it's a new nucleus, but it's branchial motor. But the important thing to remember, it's going to innervate striated muscles. It's the nucleus ambiguous. Functionally speaking, when it comes to testing, it only innervates one muscle, the stylopharyngeus, and we cannot, as SLPs, differentially test that. So when we test 9, we're going to kind of forget about motor. It does have a motor component, but it's just this one muscle. It goes from your styloid process to the side of your pharynx. It's not very big. If somehow you had a problem just with that, I don't think you'd ever figure it out, but you will figure it out from the other things. All right, then there's a general sensory component, and that involves the general sensation from the oral pharyngeal port down to the adductus laryngeus and the upper esophageal sphincter. So it's the whole pharynx, but not down into the larynx. The adductus laryngeus is the opening into the pharynx. It's created by the tip of the epiglottis and just kind of like a membrane that goes down the sides. You can close it, but when you're breathing, it's open. When you swallow, you close it. We'll do that in another course, of course. But that needs sensation. So when you need sensation in order to be able to sense when something is going down there and you're going to swallow it, hopefully, and have a swallowing response. All right, and then there is a special visceral sensory component too. It goes to those afferent neurons go to the nucleus solitarius, which you've heard about now. What else went that we've talked about today? From the anterior 2/3 of the tongue, the neurons for taste went to the solitarius. And so I said the posterior half, sorry, that's wrong. It's the posterior 1/3. And basically that's the part of the tongue that you can't see by looking in the mouth. When you have somebody open their mouth and stick out their tongue, you're looking at the anterior 2/3. The posterior third is more vertically oriented. It forms actually the front wall of the pharynx. All right, and then there's a visceral motor component to it. These neurons innervate the other salivatory glands. They come from the inferior salivatory nucleus, but I put them in red because I wanted you to know I hadn't completely forgot about them, but we're not going to test them as SLPs. And so as far as I'm concerned, you can forget about them, but if you ever hear about it and want to know, well, there it is. It's in your book too, of course. All right. We just need to kind of review nucleus ambiguous again. Remember, nucleus ambiguous is a long nucleus, and here it is, cylindrically shaped in the medulla, and it does innervate a lot of very important muscles that we will test, but not this one because it's only one muscle, but it does innervate it. So you could say it innervates all the muscles of the pharynx, including this one, which these neurons happen to go with 9. But most of them are going to go with 10, and we will look at those in more detail. And then for general sensation, the neurons go from the posterior third, from the pharynx, excuse me, the entire pharynx, back to why did I get lost here? I guess maybe I didn't put where it goes back to, but I said it in the previous slide. General sensation, it actually goes what nucleus to the spinal nucleus of 5. We're not going to test that nucleus, but we do test for general sensation of the facial region. excuse me, the pharyngeal region. And how do we do it? Just by touching with a little Q-tip or something at the back of the throat on each side. If you have a problem with that, there's going to be an impaired gag reflex. Also, they do a little test during FEES, which is fiber optic endoscopic evaluation of swallowing, in which they give a puff of air back there someplace, and if the person reacts, they have sensation. Normally they'd react by closing their larynx, and if they don't, that means a loss of sensation. Okay, yeah, let's leave the rest of it. Okay, now we get to the vagus nerve. There, again, there's branchial motor function, and that that function is subserved by nucleus ambiguous. Branchial is, we discussed that already several times, but the important thing to remember is it innervates that branchial motor nucleus innervates muscles that are up in this area. All right, what does it innervate? All the intrinsic muscles of the pharynx. Yeah, where do I say that? Yeah, do I say that here? I refer here to the, oh, here it is. Okay, so you got the vagus nerve, and it comes down in your neck, and the first thing it drops off is the pharyngeal branch of the vagus nerve, and that one then branches out into all the muscles of the velum, except for one, the tensor veli palatini, and all the pharyngeal muscles, except for these couple little ones, which we referenced for other cranial nerves. So I just think of as 10 as being the muscle that innervates the pharynx and the intrinsic larynx. All right, and the main branch for the pharynx is the pharyngeal branch, which is the very first branch off the vagus. You know, the vagus is really long, so as it comes down, it's dropping off other branches that have names. Okay, let's see. We have all the intrinsic muscles of the larynx getting innervated, and I should say a little bit about that. The recurrent laryngeal nerve innervates almost all of them. What are they? You know, well, how many intrinsic muscles are there? 6 or 8 or something like that. You can review in your anatomy and physiology, but it's all your intrinsic muscles which open and close and tense and so forth inside the larynx. And there's just one exception, and that's the cricothyroid. It's an intrinsic muscle, but it is not innervated in quite the same way. It's got its own little branch. So the superior laryngeal nerve is going to go to the intrinsic muscles of the larynx, and it's going to drop off. It's going to drop off an internal branch, and that internal branch carries neurons to only one thing, that muscle. All right, and then the recurrent, which goes way down in your chest and loops up and comes back, that carries information for all the other intrinsic muscles. As SLPs, I don't think we kind of dissect it quite like that. You will see occasional patients who only have diplophonia, meaning they phonate with 2 pitches. And that means that they have different tensions on their 2 different vocal folds, because there's a problem with this nerve. When you hear diplophonia, that almost certainly means it's this nerve. And so you can see it's a very focal pathology. How would you get it? Surgical injury or some kind of traumatic injury. That's basically how you would end up with diplophonia. Much more likely is injury to the recurrent laryngeal nerve. Why? Because it's really long. So it's going to loop down in your chest, under your aorta on one side and under your branchial carotid, I forgot what, another artery on the other side. We'll get to that when we get to arteries, we will. And it's going to come back up. So it's about so long, meaning it's just more vulnerable to injury. And one of the things it goes through the thyroid. So a lot of times with thyroid surgery, that recurrent laryngeal does get nicked. So it's going to be a much more common thing that you'll see damage to recurrent laryngeal nerve because of its length and location, and then you'll see weakness of all the intrinsic muscles on that side, except for the cricothyroid, but that's just the pitch regulating muscles. And what happens with those people, if they have damage to a recurrent laryngeal nerve, is they can't fully adduct or abduct the ipsilateral vocal fold. So they will have dysphonia for sure. It'll be a hypofunctional dysphonia, meaning breathy, and a hoarse, it can be hoarse and breathy. And they may have trouble inhaling rapidly. That can be a functional deficit for them. Usually it's not real bad, but it can mean that they can't go, they can't go, it's going to go, like that, because that one vocal fold, when you go, is your vocal folds are strongly abducting, and that one vocal fold cannot. It's stuck in the paramedian position, so they can't get air in quite as fast, which can have some functional limitations for them. If they're in the marathon, probably not going to be so good after that problem develops. Okay, then visceral sensory. The nucleus involved is, again, that nucleus solitarius. And where's it visceral sensory for? Inside the larynx, the laryngeal vestibule, and inside the trachea, and inside the esophagus too. So it's everything below the territory of 9. You need sensation there too. Like if you inhale a little piece of rice, for example, and it ends up in your trachea, you're going to feel it, and you're going to keep coughing. If you're normal, you're going to keep coughing until you get it out of there. And what is the pathway? The vagus nerve, if it's down here, would be the recurrent laryngeal nerve carrying the information back to the nucleus solitarius, which is going to stimulate your cough reflex. All right, there's a visceral motor component. I put it in red because we're not going to study it. It's a dorsal motor vagal nucleus, and it's really, really important, but not for us. It's a nucleus in the medulla that carries motor neurons, 2 smooth muscles that regulate digestion, urination, bowel movement, sexual arousal. It's kind of like all your internal organs get input from that vagus nerve and this particular nucleus. So vagus nerve is a really big nerve, a really important nerve. It's actually literally big because it has a lot of different neurons subserving different functions, but we're just concerned with what's in white here. All right. This is a little detail about what I've just said. That was a lot of information. I want to look at a little more detail at the superior laryngeal nerve in this particular one and the recurrent laryngeal nerve. Here is a vagus nerve, and it's dropping out of the floor of the skull and coming down only a short distance. It's deep in the neck, actually. So it's deep in your neck, and it's trying to get down there, and it's starting to drop off its many, many branches. We're concerned with the ones here. Here's a vagus nerve that's going to continue down into the body cavity and go to the, the stomach and all those different things we went through. We're not worried about that. But we're concerned with this one, and this is the superior laryngeal nerve. And you can see it branches into 2. One is the internal branch of the superior laryngeal nerve, and that's totally sensory. It's sensory for the inside of your larynx, the laryngeal vestibule, the cords, all that. And what's it going to carry the information back up to? Nucleus solitarius, because this is a vegetative kind of sensation. And then here's the external branch of the superior laryngeal nerve, goes to one muscle. It's important for us, the cricothyroid. That's the pitch regulation muscle, and it's if there's a problem with this nerve, not this nerve, but this nerve, you're going to have diplophobia. Actually, if you'd have diplophobia here too, but then you'd have a loss of sensation inside. Or if you have here, no loss of sensation, but just diplophobia. All right, so I think we took care of that, and now we go back to this. Here is the vagus nerve, and you can see it's dropping off things as it goes. Down here, this one is on the left. There's a right side too, but it's not depicted here. Here's the vagus nerve continuing on out, but here's its recurrent laryngeal. You can see from looking at the picture why it gets its name recurrent laryngeal, because it recurs, it comes back up where it sort of like where it started. It loops under here and it comes back up, and it's going to be carrying some information to other things, but we're worried right now about this. It comes up to all the intrinsic laryngeal muscles, and also some of these fibers are carrying afferent neurons that provide sensation below the vocal folds in the larynx, below the vocal folds in the larynx, in the trachea, and in the esophagus. So you see here, these are these branches. This is a nice illustration of why whenever you have a referral for a voice client, typically those will come from ENT doctors, but not always. And they have sent them to you because they've cleared them of a problem such as I'm now going to talk about. But if you do get a referral by somebody, it could be a physician, it could be somebody, if you have an office, they could call you and say, hey, I have a voice problem, can you evaluate me? And you're not going to say yes. You're going to say, yeah, as soon as I get an ENT consultation for you, we can evaluate you. Here's an illustration of why, and it's not the only one either. This is a great, big, huge artery, and curves tend to develop aneurysms, meaning bubbles that could burst. You can get an aneurysm anywhere, but they tend to be around curves because they're subjected to greater hydraulic stresses. And so if you get an aneurysm right here, which is not real uncommon, you don't feel it. You could wait long enough until it bursts, and then you're probably going to die very quickly, actually, because it's a huge artery. But the first sign will be hoarseness. Why? Because the recurrent laryngeal nerve is getting stretched and it doesn't work so well then. So the patient gets hoarse. And if the ENT looks, they will see a unilateral, ipsilateral with the pathology, they'll see a unilateral vocal fold in the paramedian position, like what I described before. It doesn't strongly adduct and it doesn't strongly abduct. It's paralyzed. It's just kind of stuck in the median. And then they will think of this and they'll get the test for it and go from there. So we never, ever, ever, and there's no exception, evaluate voice patients until they've been cleared by an ENT, who's going to look at their larynx and start there and then go from there. All right. Of course, another reason you may have a dysphonia is you've got something growing on your larynx. So for a number of reasons, we always do voice evaluations only after cleared by an ENT. All right, I think I've done about as much with that slide as I can. Okay, now as far as assessing and watching for signs, I think I actually have a little more. Yeah, no, this is what are we going to see with a vagus nerve? So these are the clinical implications, and it alludes to how you test. For the pharyngeal branch of the vagus nerve, if there is a problem ipsilaterally, you're going to see an ipsilateral droop of the velum and reduced elevation when you ask them to say ah on that same side. And then there's a more that we can see actually. For the pharyngeal branch of the vagus nerve, remember, it's going to innervate actually all the muscles of the pharynx, except for one, and the intrinsic laryngeal muscles. So we're going to see some signs, but not in a clinical eval, not by looking at the patient or testing or looking in their mouth or listening or anything like that. If you do a modified barium swallow as a swallowing test, or a FEES as a swallowing test, either one allows you to see material that's left behind in the pharynx after the swallow. And if you have a pharyngeal branch involvement, you will see ipsilateral stasis, which means residue, leftover material in the epiglottic folliculi and the piriform sinuses on the ipsilateral side. So I say ipsilateral residue left behind in the epiglottic folliculi and piriform sinus after the swallow. So that is a sign you can't, SLPs do those tests, we do them for swallowing patients, and such a patient would have a swallowing issue. So that's the way you'd see it. If you're just sitting with the patient and you're having them stick their tongue out and, testing the face and everything, you're not going to be able to see this. But you can see the droop, and that begins to say, hey, pharyngeal branch of the vagus nerve. If the way we would observe problems with the superior laryngeal nerve is that they would have hoarseness and possible, likely diplophonia. This is not something you do in your clinical eval as you test the cranial nerves, but again, in the swallowing test, they will have an impaired response to laryngeal penetration. Why? Because when you get something down into the larynx, not even down low, not below the vocal folds, but just into the larynx, into the additus laryngeus, you're supposed to cough. But if you don't have a sensation, you don't. So we will see this. Now, the problem with our bedside clinical eval without benefit of instrumentation is you don't know for sure when somebody is penetrating something into their larynx. You don't know unless you do the test. We're talking about modified barium swallow or fees. So this is a little iffy in terms of assessing clinically or with a standard cranial nerve examination. I hope that makes sense, because I can't avoid talking about swallowing completely, but that's really not the purpose of this course. That's 543. All right, for recurrent laryngeal nerve injury, and we're talking about peripheral nerves here now, not central, there's going to be impaired inspiration. Why? Because they can't get their vocal fold on the side of the impairment completely open. There's going to be hoarse voice. There may be aspiration. We won't see that in our cranial nerve examination. You've got to do a modified barium swallow or a fiber optic endoscopic evaluation of swallowing. And these would be especially characteristic if there's bilateral injury. If there's bilateral injury, there's very likely not due to peripheral, because it's kind of unlikely that you get two nerves on two sides involved. It's more likely in the brainstem. All right, so let's see, I think we kind of covered that. If you do have a recurrent laryngeal nerve injury, the affected vocal cord is in the paramedian position. And this is common. It's common because especially the most common cause is, it can be traumatic injury. That's fairly common if there's any kind of injury to the neck. This is a pretty superficial, the recurrent laryngeal is fairly superficial. So it can be injured from the outside. But thyroid surgery, your thyroid is right here, and this nerve goes through the thyroid to get to where it's going in the larynx, and it's very easy to injure it. And so you get this problem. Vocal fold on the affected side in the paramedian position. Okay, we're almost there, actually. This one's easy because I'm just going to kind of go over it pretty quickly. The spinal accessory nerve, it has two parts. I'm not going to deal with that. One part is nucleus ambiguous, and the other part comes from down in the spine. That's why they call it spinal accessory. But as far as if you're going to test it, and I usually don't because I'm dealing with very sick people, the way you do it is you just look at them sitting here and you ask them to elevate their shoulders against resistance. And then you ask them to turn their head against resistance to each side. And what you're doing in those two different tests is you're looking at trapezius. Typically, if they have an injury of the nerve itself, they have a droopy shoulder on the affected side. They may look symmetrical, and they elevate less well against your resistance of putting your hand on their shoulder and pressing down. Also, this nerve controls the sternomastoid, which turns your head. And you can kind of feel this on yourself. If you turn your head strongly to the right, I'm using the left muscle. So you will find weak head turning to the side away from the nerve damage. Okay, so if I turn to the right, I'm using my left sternomastoid. And if I can't do that very well, if I don't turn to the right as strongly as to the left, it means this muscle is involved and that nerve is involved on that side. If we're talking about upper motor neuron damage, we don't worry about it because these muscles are innervated bilaterally. They're basically, remember we said all the torso muscles, bilateral innervation. So if you get unilateral upper motor neuron damage, you don't see the effects. So I guess that's one of the reasons, in addition to patient endurance issues, that I don't worry about this muscle. I don't worry about this nerve because I'm not going to see involvement very often at all. In the kind of patients who have aphasia and traumatic brain injury, it's all up here. And so for me, it's kind of peripheral. What is a peripheral nerve? But of the peripheral nerves, it's peripheral. Pardon me if I'm looking up here all the time, because I don't know why. I've got nothing to look at except this big bright light and then my picture. So I tend to be looking off to the right a lot. I realize that. Okay, this is pretty important, the hypoglossal nerve. And it has just one function for us, the intrinsic muscles of the tongue. That's it. It's somatic motor, but remember the important thing of branchial motor, somatic motor, striated muscles. So where they came from embryologically, not too important for us clinically. And let me see what this next slide says. Oh, the next slide is kind of blank. Yeah, well, okay. So going back here, sorry, I don't know how I got a blank slide. So it's the nucleus is the hypoglossal nucleus, which is a long cylindrical nucleus in the medulla. It innervates all intrinsic laryngeal muscles. Here's the pathway. And notice it kind of blends with C1, C2, C3. We're not worrying about that. We're just using this to note the hypoglossal nucleus, which drops out of the base of the skull, goes to the intrinsic laryngeal muscles. That's it for this illustration. Okay, now coming to this one. This is kind of important in a way, just in terms of understanding the system. The hypoglossal nucleus is important, and it's predominantly crossed upper motor neurons that come into it. But there's a lot of bilaterality too, and it breaks down into this. All the intrinsic muscles, except for the genial glosses, receive bilateral upper motor neuron input. The genial glosses receives predominantly crossed upper motor neuron input. So what the implication of that is that the one of the clearest tests we can do show us the effect of that one muscle. And it is the genial glosses. It's a really big muscle. It's your whole tongue. Like if you were somehow able to get rid of every other intrinsic muscle and just look at the shape of the genial glosses, you'd have the shape of the tongue. It goes everywhere. Then intermixed, you have the transverse and the vertical and the horizontal and all those intrinsic muscles which help to shape the tongue. Those are all innervated bilaterally, but the genial glosses, which is a big muscle, is predominantly contralaterally innervated in terms of upper motor neuron input. And the implication is this. It's simple. If you have unilateral hypoglossal nerve damage, the nerve, not the upper motor neuron pathway, the nerve, you will have weakness on the same side of the tongue. Let's say it's a right hypoglossal nerve that has somehow been damaged. And you ask that person to stick their tongue out. It's going to deviate to the weak side, and that will be the right side. That's where the damage is. And why? The genial glosses got two halves. And so if you just think about the two halves pulling out, they're pulling, the muscle is actually attached right here. So it's pulling the mass of your tongue out. And the other intrinsic muscles are just shaping it. So if I want to protrude my tongue, I shape it and protrude it with the genial glosses. Shape it with the other intrinsics, and protrude it with the genial glosses. And so you got two halves. This is weak. It's not going to go, it's not going to move. So I'm going to go like that. I'm going to deviate to the weak side. So that would be for a unilateral right, this is my right hypoglossal palsy. And the other thing we'd see that would tell us it's a lower motor neuron issue is if you just look at the tongue and the floor of the mouth, the right side of the tongue will be atrophied because it's got no lower motor neuron input. What happens to muscles if you have lower motor damage? The muscle that would get that input becomes atrophied. It wastes away. It becomes literally smaller. So you look in the mouth, and the right side of the tongue is smaller than the left side of the tongue. It's quite obvious. The other thing that happens is those little muscle fibers have what's called fasciculations. With lower motor neuron injury, they fasciculate. And what it looks like is, if you just look at the surface of the tongue, it looks like there are worms underneath going, like this. It's not very pronounced, but it is apparent. So they have fasciculations and atrophy on the side ipsilateral to the lower motor neuron injury, and they'll have diminished, they'll have tongue protrusion to the weak side, in this example, the right. All right, now let's say it's an upper motor neuron injury. You look in the tongue, you look in the mouth, and you look at the tongue, you don't see the atrophy, and you don't see the fasciculations, number one. Now we're going to ask them to protrude their tongue, and it's going to go to the weak side, of course. And the fact that they don't have fasciculations and don't have atrophy tells you it's upper motor neuron, and it tells you it's on the opposite side. So the tongue deviates to the right. It's an left upper motor neuron injury. And most typically, as SLPs, we're going to see that patient many, many, many times. And here's what we're going to see. We're going to see a patient who, for example, they protrude their tongue, the tongue deviates to the right. And then we're going to see some other things too, because it's upper motor neuron issue. It's in the brain, not just the nerve. We're going to see a right facial droop on the lower 2/3. We're going to see a right side hemiparesis of the body, torso preserved. And you're going to see, more involvement of the upper extremity, less of it's going to be very, very, very common. So that's what you're going to see with the typical patient who has upper motor neuron injury that's someplace upstream from the hypoglossal nucleus. It could be in the pons, it could be in the midbrain. Very often it's going to be in the internal capsule or the cerebrum itself, even the cortex itself. All right. Now, so we did that. All right. Now, just a little bit about conducting the cranial nerve examination. When you look at the nurse doing the cranial nerve examination in a few slides from now, she goes more or less nerve by nerve. She does number one, number two, number 3, 4, 6. She lumps them together and she goes through them, ticks through them. Most SLPs, and when you're starting out, that's perfectly fine. Perfectly fine. You will get the information you need. Most of us would combine our cranial nerve assessment with our examination of the orofacial structures. You just need to see if are their teeth intact? Is there anything going on inside? You want to be able to describe the anatomy and surface of the orofacial structures, as well as the cranial nerve function. So that means our cranial nerve examination is going to be done in the context of an oromotor examination, which I know you've already done. And we tend to do that by not organizing it by cranial nerves, but by organizing it by parts and what in order to make it efficient. Basically, that's what it is. So I just want to make that test be as efficient as possible, particularly on acute care patients who don't have much endurance. So this whole thing is going to take about 30 seconds, maybe a minute. It's not going to take the 13 minutes that the nurse takes. But of course, she's explaining it too, so I know she does it faster. So here's how we're going to organize it. I'm going to look at the face at rest. I'm going to observe the symmetry of the eyebrow elevation and the eye closure. I'm going to look at the lips on retraction. And what am I doing when I look at that? That's just looking here. And I said, okay, go like this, done. I've just examined 7, the motor components of 7. Then I'm going to look at 5. I'm still out here. Here, 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 in the mouth, here, here on the top, here, here on the bottom, light tactile stimulation, eyes closed. I can do that, and usually I'm just going to do here. I'm not going to bother there, okay? Because I don't think it's going to make any difference to my diagnosis or my treatment plan. Okay, then I'm going to look at sensate. Why do I have that? Oh, this is just a breakdown. So here I have 8 to 10 for 5, and here I have where they are, the 4 zones, and you know, the fact that we're gonna, if we do taste, we might, but most SLPs don't. So I'm gonna do here and here for light tactile, here and here, and the 4 points inside the mouth, and I'm done with that. Now all I have to do is I'll have to look at the velum. I'm gonna look at the velum at rest, and I'm going to look at the velum during phonation, and I'm looking for degree of elevation overall and for asymmetries. And I'm going to look at the protrusion of the tongue. First of all, I'm going to look at the tongue at rest, because I want to see if there's atrophy or fasciculations. And then I'm going to look at tongue protrusion, and what am I examining? 12. All right. Well, we haven't done mandibular. So the way I'm going to do that is I'm going to feel here and ask them to clench their teeth. I'm going to ask them to open their jaw against the opposing force, and I'm looking at overall strength. And then I'm going to ask them to protrude the jaw, and I can look for symmetry of weakness, which I'm only going to see if there's a peripheral nerve pathology, because these muscles are bilaterally innervated. What's not bilaterally? What's not bilateral? Lower 2/3 of the face is contralateral, tongue is contralateral. Everything else up here we're talking about for speech is bilaterally innervated. So you shouldn't be seeing asymmetries unless there is a lower motor neuron or a peripheral nerve problem. Observing and testing the pharynx. I'm going to do light tactile stimulation for the territory of 9, which is the back of the throat, basically. And then for motor functions, I can assess very globally by listening to phonation. If you don't hear any dysphonia, you can pretty much assume that the motor aspect of 10 is intact. We can also do instrumental assessments of swallowing, the modified barium swallow, and that will provide information about the motor functioning of 10, as we talked about that before. Also, this is a reminder, we're testing 10 when we listen for dysphonia. We can hear hypofunction. That will tend to be lower motor neuron involvement that's producing a flaccid weakness of the intrinsic laryngeal muscles. We can see hyperfunction, spastic dysphonia when somebody has upper motor neuron lesions in the pathway to the larynx. And we can hear diplophonia when somebody has unilateral involvement of a superior branch of excuse me, I'm stuttering, the involvement of the superior laryngeal nerve or its external branch. They'll both get you diplophonia. And then we can see evidence in fees and heat. But again, for this course, where am I going here? For this course, we're not dealing with any details here. I simply want you to be aware at this point of the availability of tests that SLPs do, but we're only doing clinical evals, that which you can do with just a patient and you for this course. And these instrumental assessments are for swallowing that we'll do in 543. Okay, all right. Here is a demonstration of the cranial nerve, which I'm not gonna sit here with you and do it, but you watch and just again realize that most SLPs will leave off CN1 and they will only screen for 3, 4, and 6 by looking for strabismus. And if they see strabismus, they're gonna ask the patient if they have any visual problems. They're probably gonna say, yes, I see double. And when they close one eye, they don't see double. So that's the way that works. And then here is that video. What's this one? Click here for a demonstration. Okay. Oh, this is, I think it's longer than 13 minutes, but I might be wrong. This is simply an explanation of the cranial nerves in somebody else's words. I call it a supplemental explanation, so you can forget it if you want to. If you're feeling like you want to hear it in somebody else's words other than me, and I can understand if you do. I think it's a very nice little kind of summary. It doesn't give much new, but it rehashes the old stuff that we've gone through in different words. I think that is just about it. Okay, now, next time when we go into class, you will have already done everything we've done, and you looked at either the one video for sure, and maybe two, and then we're going to go through these problems. So you may want to work through them in advance, but this is what we'll do in class. And assuming we have time, which I hope we do, because we want to do something else, which is kind of the other end of what you're looking at here. This is all site of lesion and predicting what the manifestations of that, the clinical manifestations, what are the observations and the test results that you would see. In real life, you start out with your observations and your test results, and you go the other way. You think, well, where in the brain would the damage be that would account for that? And you're always looking for one point of damage, not two. It's one of the, one thing that people, when they're learning their neuroanatomy, first say, well, I can account for that set of signs and symptoms with a lesion here and a lesion here. That works. No. What single lesion can account for everything? Sometimes it can't, but mostly it can. And so that's what we're trying to do. All right, that is it. I'm going to stop sharing the screen, and I'm still recording. I'm going to stop recording and say goodbye. It was wonderful, and I'll see you next Tuesday.